Now we're going to move from acute pancreatitis to chronic pancreatitis. So in chronic pancreatitis, we have chronic inflammation, and as we've seen in a few other conditions, that chronic inflammation can lead to fibrosis and ultimately atrophy of the pancreas in this case. As you might have thought, chronic pancreatitis is often due to recurrent episodes of acute pancreatitis, but it could also be idiopathic or secondary to things like alcohol abuse or cystic fibrosis. So here you can see that if you have this chronic inflammation in this area, sometimes it heals up, but other times you have this chronic inflammation and you'll get fibrosis and scarring. So the features, what does that look like? Again, that's going to look like that epigastric pain we saw before that radiates to the back. Another common thing they like to mention is that you might have pain that worsens after eating, presumably because you don't have enough bicarb to neutralize it, among other things. And so you're going to get weight loss over time because you're due to food avoidance. The labs differ a little bit in chronic pancreatitis because you can't rely on amylase and lipase as much. If you think about it, in acute pancreatitis, you'd expect amylase and lipase to be very elevated because you're secreting some of your overactive trypsin molecules are entering your bloodstream, and you'll see those. However, in chronic pancreatitis, because you're secreting so few enzymes in the first place, even if they do have a little overactivation, it may just appear as normal or low for you on a lab test. On imaging, you're going to have a characteristic chain of lakes pattern due to pancreatic duct dilatation or pancreatic calcification. And here you can see the ducts right here. Here's your pancreas. You can see this chain of lakes, formation. Some complications you should be aware of. One is pancreatic insufficiency. This should make some sense. Normally, you have a collection of enzymes that are secreted, lipases, proteases, into the lumen. But if you have so much pancreatic damage, you're not going to have all these enzymes anymore that are being released into the lumen. Another complication to keep in mind is that you can get secondary diabetes. So what happens here is that this chronic inflammation damages all pancreatic tissue. It's not just the acinus and the ducts. It can also damage your nearby islets of Langerhans. And if those get damaged, you could potentially have secondary diabetes if enough beta cells are injured. There is an increased risk of pancreatic cancer with chronic pancreatitis. And this isn't unique to just pancreatitis. This is pretty much anything with chronic inflammation can cause some sort of cancer. We saw chronic inflammation in the mouth and oropharynx can cause squamous cell carcinoma. Chronic inflammation in the distal esophagus can cause Barrett's esophagus and later on adenocarcinoma. We saw chronic gastritis causing gastric adenocarcinoma. We saw UC causing colon cancer. So I just want you to keep in mind, whenever you hear chronic inflammation, I want you to think of cancer as a potential sequelae of that inflammation. And the last thing I want to talk about is rare but important. Splenic vein thrombosis is often associated with chronic pancreatitis. So what's happening here? If this is our pancreas and this is our spleen, we have our splenic vein that runs right between right in the middle of the pancreas. If you have inflammation of the pancreas, especially chronically, what can happen is that inflammation can also start affecting that blood vessel. And over time, that inflammation can cause a thrombosis. And if you have a splenic vein thrombosis, because blood is coming from here all the way over here, you could actually get a backflow here and you'll get splenomegaly. And not an important note, but something I discovered, I thought it was interesting, is that half of patients with chronic pancreatitis develop splenic vein thrombosis. So it's very common in that population. Okay, moving on, we'll talk about pancreatic insufficiency. So pancreatic insufficiency is caused by decreased production of necessary pancreatic enzymes. So as you know, our ACE and our cells secrete zymogens into the lumen, and those zymogens go into the duodenum where they are converted into active proteins, proteases, and lipases. But in pancreatic insufficiency, we secrete less of these zymogens, and we end up ultimately having less active proteases and lipases in the lumen. This can be caused by a number of different factors: cystic fibrosis, chronic pancreatitis, pancreatic surgery, and cancer. So in cystic fibrosis, what happens is that, as we know before, our ductal cells are responsible for secreting bicarbonate and other components of pancreatic fluid. And part of making this process works requires a functional CFTR protein. And so if you don't have a functional CFTR protein, you have a few things happen, but ultimately what's going to be the end result is that your lumen will become viscous, as you can see here, and nothing can get through. It's kind of like a sludgy material. And because of that, you're not going to have the free flow of proteases and lipases into your lumen. In chronic pancreatitis, we just saw this a second ago. What's going to happen is this chronic inflammation here will damage the pancreatic tissue, and you'll lose a lot of the ability of the ACE in our cells to produce your pancreatic enzymes. Pancreatic surgery is pretty self-explanatory. If you don't have a section of your pancreas, you're obviously not going to have a lot of some proportion of your pancreatic enzyme potential. And in pancreatic cancer, what can happen? A few things. The cancer itself can destroy your ACE in our cells, so it would have the same effect as pancreatic surgery in the sense that you are losing ACE in our cells, so you're losing enzymes. You can also have the cancer obstruct a lot of the outflow tracts. So even if you have some functional ACE in our cells, you'll still run into the problem where the zymogens can't escape into the duodenal lumen. And how this will present, it'll classically present with steatorrhea, which is fatty stools, as well as fat malabsorption. So this is from our small intestine lecture about how fats are dissolved and absorbed. Basically, you'll have these big fat cells. They're going to get emulsified by this amphipathic bile. And after doing that, these pancreatic proteases right here can start to chip away at these fat globules, and they'll ultimately decrease them in size as they keep working at them. And once they're this small, they can be absorbed into enterocytes as micelles. The problem if we have pancreatic insufficiency, we don't have any of those lipases anymore. So these globules can't be converted into a size that fits into enterocytes. So we have these large globules, they don't fit in here anymore. And so they're just going to keep traveling down the intestine. And ultimately, these will be excreted along with the stool. So you'll get steatorrhea. Any condition that can cause fat malabsorption can also cause fat soluble vitamin deficiencies. So I've talked about this quite a bit in other lectures, but I always like to remind you that vitamin A deficiency usually presents with night blindness and some skin changes. Vitamin D is commonly associated with hypocalcemia and bone problems like osteoporosis. In vitamin E deficiency, you'll get hemolytic anemia is probably the most important symptom to realize. And then because vitamin K is a cofactor for a lot of our clotting factor synthesis, if you have deficient vitamin K, you're at risk of bleeding. Pancreatic insufficiency can also lead to vitamin B12 deficiency. From our framework that we've discussed now in a few different lectures, here is our vitamin D absorption. And I don't want to go through the whole thing. I just want to point out here that pancreatic proteases are essential for this process because they actually cleave the interaction between B12 and R binder to give you a free B12. And this free B12 in your small intestine will then bind to intrinsic factor, and it'll travel to the terminal ileum and get absorbed. If you don't have this protease here, you're going to have the B12 stuck to R binder, and this complex cannot be reabsorbed in the terminal ileum. So that's why you need these. And in pancreatic insufficiency, you obviously don't have enough proteases entering your lumen. And I think that's what this just says here. So moving on to the diagnosis and treatment. So there's a few different laboratory values that you should know with pancreatic insufficiency. You can have decreased duodenal bicarbonate. So remember, the pancreas is important for secreting bicarbonate in the presence of secretin, as we've talked about. And so if you have pancreatic insufficiency, you're not secreting as much bicarb. So it should make sense that if you have a dysfunctional pancreas, you're going to have decreased duodenal bicarbonate. Another thing you'll see is decreased fecal elastase. So elastase is one of the pancreatic enzymes that is secreted into the lumen of the duodenum. And so here in a normal functioning pancreas, you'll have a ton of enzymes, and let's say the yellow ones are the elastase enzymes. You can detect this enzyme in the stool to some extent, whereas in pancreatic insufficiency, you're not going to have as much of that detectable in the stool. So that's why you have decreased fecal elastase. The fecal fat test is pretty self-explanatory. It's just testing for the presence of fat in your stool. So going back to our slide earlier about steatorrhea, this is fatty stool. So this would be a positive fecal fat test if you ever detect any of these fat globules that make it all the way to your stool. And the last one I want to talk about, and probably the one that's tested on most, is that in pancreatic insufficiency, you'll have a normal d-xylose absorption test, meaning that d-xylose is detected in the urine. So let's break that down again. We talked about this once in the small intestine lecture, but basically here is how simple monosaccharides are absorbed in our lumen. So this is the lumen of our duodenum, and this would be the basolateral layer and into the bloodstream. As you can see, these simple monosaccharides just require intact intestinal mucosa to work. So the d-xylose absorption test can be used to distinguish between GI mucosal damage or another cause of malabsorption. So xylose, let's just assume xylose is one of these monosaccharides. All you need to get this monosaccharide all the way into your bloodstream is an intact mucosa. So you just need this cell, basically. As long as this cell's working, you should have xylose being able to be reabsorbed, even if you don't have anything else going for you. So how they do this is they'll give somebody a load of d-xylose, and then they'll check their urinary d-xylose levels. And how you interpret the results, if d-xylose was detected in your urine, then that means this d-xylose molecule went from the lumen of your intestine into the intestinal mucosa and out into the bloodstream, and that would ultimately be excreted and you'll see that in the urine. So if you have d-xylose detected, that means d-xylose was absorbed appropriately, which means this whole section here is working. This whole cell, in fact, is all working. And so if you know this intestinal cell is working, that should point you in the direction that, okay, maybe the intestine isn't the problem. So that suggests that it could be something like pancreatic insufficiency that may be causing some sort of malabsorptive pattern for other compounds. If d-xylose was not detected in the urine, then obviously d-xylose wasn't absorbed in the first place. So then you can start to realize, okay, maybe the intestinal mucosa is the problem because that's all you need for d-xylose to be absorbed. And again, this would lead you to the direction of an intestinal problem like celiac disease. In the case of what we're talking about, pancreatic insufficiency, is you can notice that d-xylose was correctly absorbed in this cause. So that's why you'll have a normal d-xylose test in pancreatic insufficiency, because the intestinal mucosa is not the problem, it's the actual pancreas. You treat this, it's pretty self-explanatory. If you don't have enough lipases and proteases in your lumen of your GI tract, you need to replace it with pancreatic enzymes. And that's all you need to know about pancreatic insufficiency. Thanks for watching. I hope you enjoyed the video. Please like, comment, and subscribe for more content.